Um, oh, we're now recording. So other things coming up, we have our Free Friday series continues all the way through March. So every week, check out what's coming up every week. Wednesday Wellness is happening. So if you have time, stop in on Wednesday at noon and connect and hear what's going on in the EAP world. It's a great opportunity to network and to really help solve problems and figure out if other people are going through the same challenges you are. Coming up on February 29th, we have a new program for SEEP candidates who are going through Pathways 3, or anybody who's been in EAP work for less than 3 years. I highly recommend you attend this. It's a two-parter on the same day. So on the first part, on the 29th, from 1 to 3, it's going to be the fundamentals of EAP. And then from 3:15 to 4:15 is about labor unions. We're really excited. We think that it's a really educational program. So if you have a colleague who's less than 3 years, highly recommend that they attend this. If you're just interested in learning about labor unions, you can just apply and come on, register just for that 1 hour, which is only, I think, for a member, $29. So it's very cheap. So that'll be coming out in shortly. It's already up on the website. Registration is open. I will say we had a banner group on Elevating Ethical Awareness, 80 people. May 2nd is open. So if you need Elevating Ethical Awareness, you want to register now, or you can think about coming to Indianapolis. We are rapidly working on Indy. Speaking of which, there's a call for proposals out. If you are going to think about speaking at the conference, now's the time. We also have a call for posters out. So if you want to do a poster, if you were in Portland, you saw our poster session. Very exciting new aspects of the conference. So we ask you to think about those things. The proposals are due March 15th. We have volunteer opportunities. The JEA, the journal, needs more assistance with writers, editors, even people who just want to come up with ideas for the journal. We also need more Wednesday Wellness hosts. And we need some more folks who are SEEPs to help coming up with questions and even giving our SEEP a little spit shine for making it more professional and more up-to-date, more modern. So lots going on. Check out the website. Lots on the education front, lots on the volunteer front, and you'll be getting it all out in an e-blast this afternoon as well. So with that, I'm going to turn it over to Shannon, who is with Newport Healthcare, and let her take it away. And Shannon, why don't you tell everyone about your background?
Thank you. Well, first of all, I have a background in IT, but it doesn't seem to be working very well for me this morning. I first joined into the Teams instead of the Zoom, and then so once we figured that out, I got in. But then decided now my camera decided not to work, so I think I've got it all figured out for today. My background is in IT, and then also in mental health for the last 16 years. So what I'm going to talk about today is kind of the journey of discovery through my time in mental health. So while I'm going to use Newport kind of as an example of how we deal with different types of trauma, I'm going to use examples from several journeys that I've encountered throughout life. So I'm excited to be here today, and I really appreciate all of you in attendance. I don't know if some of you attended this presentation at the national conference, but the feedback was pretty good, and so I'm happy to share it again today. And I've made a few edits to it because, you know, like anything that, if any of you have ever authored anything, every time you read it, you change it. So that's kind of what I've done here. So if you've seen it before, you might see a few different things today. I am going to go ahead and share screen. Let's see. Here we go. Can you see my presentation? Okay, we got a thumbs up. Okay. Now if I get it into mode here. Okay. So what I'm going to talk about today is just kind of like, you know, kind of first of all, you know, who are we and why should you care? I'm going to kind of minimize this here. And then we're going to go through different types of trauma. I'm going to focus a lot on how generational trauma affects us in the business world as a family and mental health wise. Some of you may have heard of the adverse childhood experience test. We're going to go over that, and I'm going to kind of ask you that as we move through these slides, you're going to be triggered to think of someone, maybe somebody in your family, somebody you work with, maybe yourself. But just focus on that. And when we take this test, have that person in mind when you kind of come up with what their score might be. A simple test is 10 questions that give yes or no to come up with a score. Then we're going to talk about a couple of books that I've used in my studies that I highly recommend, and some stories from those books. And then we're going to move into kind of where do we go from there? Like so now that we know this, what do we do? What's available to us as far as levels of care versus medications or a combination of that, and also how to identify resources for yourself, your family, your employees, whoever you may be thinking about as we move through this presentation. So I will be using Newport as one of the models of reference for this presentation. And just to kind of give a short background on what Newport is Newport is a mental health primary residential treatment. We specialize in teens and young adults, which is a population in great crisis right now. And then specifically with the higher acuity, like mood, co-occurring disorders such as depression, anxiety, trauma, OCD, mood disorders, self-harm, suicide ideation. Also the gay, lesbian, queer, as well as transgender populations that are having challenges. I'll touch on that briefly. That in itself can be an entire presentation, but we'll use different examples from these as we move through. And you'll see Newport Healthcare as our main name, but we have the Institute for Young Adults and the Academy for teens, ages 12 to 17. Some locations, depending on state, go up to 18. So what I want to kind of start with, and I'm sure you've all heard of this before, but that we need to look at root cause. We have a country that consumes nearly 90% of the medications in the world, because we are really being conditioned to believe that everything we feel that is unpleasant is something that can be treated with a pill. And while we can use medications to help get through some situations, it's not a permanent solution in most cases. In some cases, it is. But in most cases, it's being used as a permanent solution when it's intended to be a temporary bridge. And what we're going to focus on in this presentation is looking at root cause of these conditions. So when we look at, and what this focuses on is that manifestation of trauma to medical condition. And this is where it starts, a root cause being trauma that then presents itself as disorders that are diagnosed as such as anxiety, depression, mood disorders, PTSD. And then many of us even add on to that, most of us will add on to that maladaptive coping mechanisms such as substance use, self-harm, like cutting, eating disorders, whether it's restricting or overeating. And I think we could probably 99.9% of us could admit to a little bit of dysfunction with devices. So just a little bit of stats here from CDC in relation to our younger population, which seems to be the higher affected. CDC tends to run a bit behind on stats. So I've got the 2018, 2019 here, but then also just grab this one statement on the bottom. But as you can see here, we have some pretty high double-digit numbers here as far as persistent feelings of depression and sadness, 36.7%. This was CDC prior to 2020 COVID. That has increased quite a bit. by like 24 to 30% here. So what we are seeing within the population that we serve, this young population, is a tremendous increase due to kind of that missing life, that development of the brain, of the coping skill, or not coping skills, but the uh, connecting skills with that younger generation that they were cheated out of. We went from let's reduce your screen time to let's live your life online, and that was a hard left for a lot of people, and it's really increased the suicide rates and ideation, depression, and certainly anxiety. Um, I work a lot with the native population, so you'll see some native themes in here. But there's a very common thing within the native population called generational trauma. Obviously, they don't own that. It's a thing for all of us, whether Caucasian, Black, Hispanic, Asian. This is something that is very prevalent. But some populations do have more prevalency of this generational trauma. And that just goes back to history. When we look at what's happened with certain cultures, that generational trauma hands down from one belief in one generation to the next, to the next, to the next. And what we're seeing is certain populations, when we say that diabetes is racist, it's really a statement that really ties back to a generational trauma statement. When we have a generational trauma that starts way back in history and moves forward and then exacerbates and maybe changes a little bit, but not a lot, what happens is we start to see these manifestation of diseases that attack certain populations. So while it is not discriminatory as far as only hitting certain populations, it's a people population thing. There are some populations that get hit harder with these diseases because of generational trauma. So the beauty of this is that with the proper treatment of the generations and the beliefs and the coping mechanisms, we can change that by building resilience and then passing that on within the generations, just in fostering healthy beliefs, healthy self-awareness, and the ability to just grow within what is rather than stay in what was. And that's really looking at authenticity and also the past, to say what can we learn from the past and what can we get some form of treatment, if you will, from the past rather than a medication, so that we can move forward and get over it, through it, around it, everything that we can in order to have it stop attacking us personally. And that's where I'm gonna jump into the adverse childhood experience test as a diagnostic tool. So these are the 10 measures that are used for adverse childhood experiences. And this is the part where I wanted you to kind of think of someone or even yourself that you think may be experiencing some form of trauma that manifests in different types of behavior. Sometimes it's withdrawing, and sometimes I'm sure we've all met someone that when a certain situation happens, they overreact, and you just think, wow, was that ever over the top? That's a trauma response. And so we've got to look at where does that trauma reside in the body and how do we address it, name it, and learn how to take the power away from it so that we can get our power back and understand when we start to feel that way, how are we going to react to that? And there's the fight, flight, freeze kind of method that people will fall into one of those three typical categories. But this is where that root cause typically exists, is within this ACE score. So you would give yourself or the person you're thinking about a 1 for each one of these 10 questions. Has this person experienced physical abuse before the age of 18? There is also this same test for adults. It pretty much measures out the same, but the effect, the ripple effect, is going to be earlier onset with these symptoms being experienced earlier in life. So, have you experienced physical abuse, verbal abuse, sexual abuse, emotional neglect, physical neglect, having a parent who was an alcoholic or using drugs, a mother or stepmother who was a victim of domestic violence, a family member in prison, a parent or parents with depression, or parents divorced. So you would assign a 1 for each yes to each question. People with an A score greater than 6 with these events are more susceptible to these diseases. I even changed the order of these just because of my own personal experience in life. I thought, I always had thought, as a person in recovery from addiction and trauma, I had always thought, well, there were a lot of things that happened to me because of the maladaptive coping mechanism I chose, the smoking, the drinking, and so on. But what I'm finding in these studies, and actually brought me personally great comfort, is that there's more to it than what I brought on myself because of the experiences that I had. And while, I'm still accountable for the actions that I took, I also have experienced things because of my ACE score. So I reordered these in a little bit just to kind of point out that with that ACE score of 4 or higher, 6 or higher, a person is twice as likely to have been diagnosed with cancer or heart disease, 4 times as likely to suffer from emphysema or chronic bronchitis, nearly 5 times as likely to experience depression, 12 times as likely to have attempted suicide, 7 times as likely to be an alcoholic, twice as likely to smoke, and 6 times as likely to have had sex before the age of 15, and possibly resulting in an unintended pregnancy. But in the top here, you can see that these events and risk factors do contribute to diseases such as depression, anxiety, heart disease, and cancer, diabetes. So what I found especially interesting, and then pulled these into this slide, is that from the epigenetics study, your behaviors in your environment can cause changes that affect the way your genes work. And the good news with that is that the epigenetics are reversible. And what I really loved I used to work with a Dr. Menestrita at a hospital in Michigan, and he would say, the genetics load the gun, the environment pulls the trigger. And that really impacts me, especially now in my life, as I have a daughter who has 2 children adopted at birth. So 2 of my grandchildren are adopted at birth, and one is currently in the process, a foster child that we hope to adopt. So they're going to be affected differently. They have very different backgrounds. They have very different genes, and also, the difference in being adopted at birth versus being exposed and already having at the age of 2 a very high ACE score. So what I like about what this epigenetic study says is that these things are reversible. And that's not just with children, it's with adults too. It really, like many things, when we bring education and awareness and support and treatment around the topics, we are able to then change the outcomes. So
Shannon,
here, yes?
I just want to say we do have a question in the chat. Frank
Okay.
asked, why is it only mother or stepmother that experience DV, not father or stepfather?
That's a great question, and it's one I've heard before. That is just what the actual study states, but I would argue that it wouldn't make a difference. I mean, one way or another, if there's been domestic violence in the home, the child is going to be affected, right? But that's how the actual study reads, the test itself. And I can actually, I'll send you the actual test that you can distribute after this presentation.
That's great.
So
Thank you.
I didn't take the freedom to change their wording because it's the actual test. But good question, regardless. So, and then just right here in the red highlighting, researchers found that even when individuals with a high ACE score did not have poor health behavior, such as drinking and smoking, their risk for disease was still higher. So again, I just want to point that out, not to defend, the diseases, but to explain that if a person were to say, and I've heard this, well, I never drank, I never smoked, but I do have, these ACE scores. And then, they end up with celiac disease or any, these other diseases, and that can actually be as a result of those ACE scores. So again, I just love to point out here that these are reversible with treatment. So the two books that I really enjoy the most on this topic of trauma are The Body Keeps the Score. This is a very popular book within the clinical arena, with just about probably every mental health therapist has this book or studied this book as part of their education. It's a very thick book. It's a very scientific book. It has things that will make you angry, but it's a good book, and it hits home. And this is where kind of my studies began, and that I really started to embrace that, wait a minute, mental health can result in medical conditions. That's big. That's science, and this is what proves it. And what's really interesting in this particular book is they share the arguments throughout history, starting in the 40s, of where they continued to present, as the DSM was created for clinical diagnostics, that mental health did contribute to medical health. And there was a fight within that board, that body, saying, no, it doesn't. And finally, they have evolved to saying, oh, it appears through these studies. Yes, it does. So now within the DSM-5, you see a lot of mental health issues being added each time they actually update this medical reference point for diagnostics. The next book that I really enjoy, and this one's not as big, so it's definitely, if you're ADHD, it would be your preferred book to study on trauma. I really love the author. She actually even is the reader of the book. So I like to listen to books on Audible. And she's got a great sense of humor. She really presents the book well. Her father was a scientist. And what I just loved about how she presented many of her cases is that she would always come back to the science of it and tell a story about her dad and her upbringing, and how, he really spilled into her practices as a pediatrician to say, let's do something besides just assign a medication. Let's look at what all the symptoms are. And what she specifically talks about is ADHD, and the high number of children that are diagnosed with ADHD that actually do not have ADHD, but rather have high ACE scores and need to actually address adverse childhood experiences. I am going to click on this YouTube clip and just play a few minutes of her presentation, because I want you to hear her take on ADHD, because it's so prevalent as far as how diagnostics work these days. Hopefully all of our sounds will work here. I'm gonna get this. Tell me if you can hear this, and I'm going to need you to verbally do that because I can't see you.
Nothing is playing and I can't hear anything.
Oh,
You can't
Yeah,
hear
nothing
anything?
so-
no,
No,
I
nothing
don't
so
see
far.
anything either.
Oh, hold on. Let me stop this then. Hold on. Okay. Are you still there?
Yes.
Yes.
Okay. The link is in the presentation that I did share with you, so that you'll be able to click that. But basically what she's saying is that greater than 95% of the children that are sent to her practice asking for ADHD meds, either a request from the parent or at the direction of a teacher, that greater than 95% of them, when she does the ACE score test with the parent on that child, has found that there are greater than 4 scores of 4 for these children, and that when they actually get them age appropriate trauma-based care, that these children can thrive. And she shares, what I really love about this book is that she tells like 3 stories at a time. She'll start one story and then she goes into the science and the examples, and then she'll start another story and go into the science and examples, and kind of leaves you hanging like a cliffhanger. But then she comes back and then she gives you a little more and a little more. I really like how she does that. But she talks about, for example, a young boy who at the age of 3, his father had lost his job, and so they took on a boarder who actually sexually molested their child. And once they learned of this, he did end up going to prison, but that child stopped developing at the age of 3 when this happened to him. And at the age of 6, she started seeing this child. He was small in size, he was underdeveloped in his IQ. And as she uncovered what had happened to him and then started working with him, got him, the help that he needed so that he could catch up and develop at an age appropriate way. So sometimes we look at the age of somebody at the onset of a trauma and think, well, they were so young, hopefully they just won't remember it. But kind of taking you back to the previous book name, The Body Keeps the Score, the child may not remember, but the body has memory. So we've got to make sure that if we see an anomaly within a child that has experienced anything adverse within their childhood, that we make sure that we take them to a doctor that is qualified to actually acknowledge the trauma, not just the symptoms, so that we can get to the root cause and get to a successful treatment and ongoing recovery. This is another book that I really like. Oh, did somebody just ask something? Oh, okay. This is another book that I like that I'll just touch on briefly, that gets into transcranial magnetic stimulation. And it's written by a gentleman that actually was eventually diagnosed with Asperger's, because he actually had it before it was a diagnosis, but he was treated as though he was dumb and lazy. So it's a great book. And he talks about undergoing and actually being part of the studies of TMS to treat his condition, and how that worked with his Asperger's and his autisms. It's just an amazing story. I highly recommend it to anybody that's doing any studies or knows anybody that has that diagnosis, because it's an amazing story. And actually, this man in his younger days, I do believe this, that many autistic individuals actually have like some kind of a superpower, if you will. And his was that he could listen to music and hear things other people couldn't hear. So he started tearing apart speakers and rebuilding them to sound so much better, that he was hired by very famous bands. And the one that he talks about is Kiss. And he was actually he was a technician for Kiss's sound effects, and then also was asked by Ace, one of the members of Kiss, hey, do you think you could design a guitar that could shoot fire out of it for me? This is the guy who did it. So his autism was his superpower. It was just an amazing, fun story that I highly recommend to anybody that's interested in that kind of a topic. So where does this bring us? When we look at, according to USA Today, Americans are 5% of the world's population, but we're consuming 87% of the world's prescription drugs today. I mean, if that doesn't make us say, wow, that's a culture thing right there. We have a pharmaceutical industry and an educational system that teaches doctors to use medication first. And while I've worked at an acute psych hospital, and I have seen firsthand where medications were absolutely necessary for the functioning of a person and society in general, I've also seen where medication was the cause of a person not being able to properly function in society. So I personally believe that we've got to look more at these integrative therapies. We've got to look more at, I love working with the tribal communities and hearing of their different type of integrative therapies that they use. Old medicine, it works. And old medicine is often grounding techniques, breathing techniques, communicating, connecting, therapy, rather than the pharma of dulling receptors so that you don't feel. There's a danger to removing the ability to feel emotions. Emotions are what help us make decisions, oftentimes decisions that are great, or in the absence of emotions, decisions that are horrifying. So I would like to see in a better world, in a true reform of healthcare, more emphasis on mental health, non-medication approaches. There's a handshake in here where we can combine medication and therapy, but using the medication as a bridge, not a crutch, not a solution. And of course, as I said, there are some mental conditions that will require medication for life, medication adjustments for life, medication reviews for life. But there are many diagnoses out there today that are using a medication until it doesn't work anymore. Then they're increasing the dose, and then they're changing it to a stronger medication, and just trading that out. And we've got to look at then what medical conditions are forming because of the medication, what it's doing to organs. Eventually that trade-off is devastating. So I would like to see where we look at things like adverse childhood experience scores, and we look at integrative therapies, and we look at trauma treatment, and actually talking about things that we were brought up not to talk about, so that we can process them and then thrive as individuals. So let's talk about levels of care. Most of you are familiar with these levels of care. If you're clinical at all, or you're an EAP, you're familiar with all of these levels of care. But I know that some of you are employer groups and you may not be familiar with this. So I'm going to talk to you about these levels of care. And I'm going to say on this slide, while the arrow is pointing to the right, that arrow goes both ways. A person may start in outpatient and then crawl up it or be solved. They may start in acute psych and then work their way down through this. So on either ends of this arrow, at the left of residential, I'm going to say acute psych. And that's going to be a person that has been deemed to be a danger to themselves or others. So maybe they are homicidal or suicidal. Once they are medically stabilized, which is usually done with medications, they are then stepped down to typically a residential level of care. Unfortunately, not every state has the legislation in place to support this level of care. That's why many people travel out of state to get this level of care. So residential care is not psych lockdown, meaning it's not locked doors, they can leave. But it is a 24/7 where a person is in that residential care 7 days a week, and they are being monitored by clinical staff. So typically a higher acuity, meaning it's not really safe or stable yet to send them home and have them in outpatient levels of care. So typically they might stay in this level of care anywhere from maybe 2 weeks to a month or 2 months, depending on the clinical presentation of the individual, what they're doing, how they're progressing, any medication adjustments that are being made that need to be under the supervision of a psychiatrist or a doctor, clinical staff. But they're also receiving mental health care as well as medical, possibly medical health care. From that, once stabilized, typically they will step down to what's called PHP, which stands for Partial Hospitalization Program. So what this is it's they're going home each night, but it's typically starts off, again, depending on that clinical presentation and the severity of their recovery from this mental condition. They may attend 5 days a week for 6 to 8 hours a day, and then maybe drop to 4 days, 3 days, 2 days, and then drop to the next level of care, IOP. So what this 3 to 5 days of PHP is, it's still like an intensive level of group therapies, individual therapies, seeing a psychiatrist, seeing, an MD type doctor for anything, again, that is part of that person's medical mental health presentation. Once they are stabilized at that level, so we can start pulling away and going lower, then again, depending on the individual, we might go with a 3 to 5 days a week. And this is where they're going to fully integrate back into a job or back into school. And so their treatment is typically in the evening, after school hours, after job hours. Many of the PHP programs will have schooling in them when they're a minor. Newport has schooling. Not all of them do. Some of them have to be taken out. Within the IOP level, their schooling is going to be at their school that they are enrolled in their state. And then they're going to, as they, again, step down from 3 or from 5 to 3 to now I'm going to do just strictly outpatient, maybe once a week, maybe then once a month, stepping down to, I am getting better. I am needing less touch. I am recovering. So then we're gonna get to that 3 or fewer days a week, 1 day a week, 1 day a month. And then post-discharge, they're going to be engaged in things like telehealth, which has been a great addition to our industry, since it really was, I'm going to say, scorned upon, if you will, prior to COVID, and then leaned upon during COVID. So it really validated the access to care for many people that wouldn't otherwise have ever gotten care, that now that's available through a lot of different telehealth, like your Talkspace, your empathy, and so on. Stephanie, who is, I forgot to introduce at the beginning of the call, she's on this call from Newport also, and she works a lot with these different telehealth therapy groups, as far as stepping up and stepping down. When they're working with somebody that they identify needs to go to a higher level of care, they'll reach out to us, and we can evaluate, assess, and then determine what level of care. And likewise, when we're treating people from areas that are either very remote, or they're just not able to with their job or their schooling or their willingness to do in-person therapy for post-discharge, then that's certainly a great alternative for them to use. I personally used it for EMDR for trauma therapy during the COVID time, and I found it to be very convenient. You don't have to drive, park. It cuts down on the time that you have to spend getting to and from, and it's just in the privacy of your own home or office. So it's a great add-on benefit that I hope that insurances will start to cover more prevalently than they currently do. A lot of the TPAs are now that for like any self-funded corporations out there are even looking at a lot of these as a layer over top of their benefits. So, we strongly shake hands with them as a partner. And then our program also has an alumni support group for parents, and then an alumni support group for teens, and an alumni support group for discharged young adults, which is really important, because there's not a cure. There's a support system. There is identifying, healthy coping mechanisms and tools and connectivity. So we want to make sure that we stay connected with individuals that are affected with mental health challenges, depression, anxiety, and so on, to continue with maintenance. So another thing that we do at Newport is that we require the engagement of the parents or guardians of the teens and young adults as part of their program. They have to be a part of the solution, especially, as we talk about generational trauma. Oftentimes what we find is that when we address or engage in the family component of the treatment, there are ruptures in the relationship between the teen or young adult and the parent that they may or may not even know about. And as these ruptures are identified, we need to have the entire family on board with, let's talk about this. And let's process this. And very often, more often than not, we're also making recommendations for outpatient care for maybe mom needs trauma care, maybe mom needs EMDR. Maybe mom needs some kind of a life coaching or something. Maybe dad needs some form of treatment as well. A recent alumni meeting that we had, where we had two of the male parents presenting to our staff on just their journey. One of the gentlemen, really, it broke my heart and warmed my heart at the same time. He was a Marine. You're never an ex, right? He was a Marine, and he was very strict with his son. And his son was having mental health issues. His son was also identifying in the non-binary area. He was not having any of it. He did not want anything to do with the family treatment. We don't do things that way in this family. He's just going to have to, conform. And after his son then attempted suicide and was almost successful with it, he came around to the fact that his system was broken, and he finally he surrendered to the family program and engaging with other parents that were having similar problems and issues. And he had to change his beliefs, and he had to change his approach to his child, so that his child could thrive and they could thrive together as a family. So we can bring the teens and the young adults into treatment all day, every day. But if we don't treat the family, we may not be solving the problem. In fact, we most likely are not going to solve the problem. So this is a required component of treatment at Newport Healthcare. So for every client that we bring in, there is virtual treatment being done with the parent or parents, guardians, and so on. And in some cases that it's in person, depending on the location, but we do have a lot of traveling patients that fly across state lines. So that's another thing that COVID brought to fruition for us, is that we used to require that in person, and now we have an entire virtual program available for families, and it has just really blown up the demand because we're meeting that demand. So it's brought, access to care, which is really the overarching goal. So another thing that's really important as we work with families is that we work with their insurance. There's a lot of private pay solutions out there, but boy, we're paying a lot of money for our benefits. So we want to use them, right? So these are just some of the plans that Newport works with. And we work a lot with what's called single case agreements. And we work with a lot of TPAs and EAPs that work with the self-funded corporations. So we work with you so that you can work with your people and keep them productive and healthy and thriving in life. And then just finally, Newport actually has a few other brand names out there. In Minnesota, we also have Prairie Care, which is 8 locations that has acute psych all the way down to outpatient, and 40 psychiatrists. And then Center for Families in Pennsylvania and Minnesota also, which is all outpatient services. And then this is my contact information and Stephanie's contact information if you would want to reach out to us with any questions, or if you have a family in crisis and you want to give our phone number to them. We do interventions on families all day long. So we're there to help them. We're there to identify resources for them. And one of the beautiful things about how we are designed is that we have over 50 clinical outreach specialists across the country that do nothing other than connect with these in-person and these virtual providers in their states and territories. So we're very familiar with the resources available for us for outpatient services as we discharge patients and families, so that we have the partners we need to step down the levels of care to people as they progress through treatment. So our network of resources is your network of resources. So if you have somebody that is having a challenge, just give them our phone number. We will listen to that challenge And if we can't say, hey, we think that Montecatini and Carlsbad, California would be a great fit for this eating disorder, what we're going to do is we're going to send an email to one email address that goes across the country to over 50 clinical outreach specialists. And we're going to keep it confidential as far as we're not going to share names, phone numbers, things like that. We're going to share a clinical profile and say, this is the challenge and this is the need. What do you have? And then we start getting these emails from all over the country for resources for that person so that we can help them. So if they're, if we're not their last phone call, we hope to be their second to the last phone call, because we're only going to bring people into our treatment that we think we can make a shift with, because that's the responsible thing to do. And our outcome studies show that we're doing that right, because all the charts are going in the right direction. The well-being is going up, the depression, anxiety, suicide, ideation is going down. So we want to make sure that we help the ones that we can, but we refer out the ones that we can't. We don't just say, sorry, we can't help you. Good luck.
Thank
Any
you so
questions?
much, Shannon. Before we're going to open it up for questions, I do want to thank Newport Healthcare. They sponsored this session today, and we greatly appreciate it. Also, we will be sending out the presentation. Shannon, you'll be able to share that with us?
Yes, I
Share
shared
with
that
me
with
and-
Julie. Okay.
Oh,
Send
okay.
that to you.
Great. Yeah.
Okay.
Or that's fine
If
with
you can
Julie.
send me your email, then I'll send you that, the outcome studies.
Sure.
And there was another thing I had said. Yes, you'll have that link to that, the ADHD doctor, the pediatrician
You too.
inside that
Yeah.
presentation.
Great. All right, let's open it up for questions then. Please use their raised hand.
Wow, I must have been really thorough. Well, you've got my email. You've got my email and phone number. If you have a question that you are too shy to ask in the Brady Bunch squares. Oh, we got Melissa.
Hi, how much body therapy do you use, like Feldenkrais derulfing, or to help the trauma move through the body and release itself from the fascia?
There are a lot of different integrative therapies that are used within our location. So there are different locations have different things. So we do a lot of nature grounding outdoor, whether it's tree hugging or barefoot on the ground, but breathing, Qigong. We do mixed martial arts. We do yoga. There's just a lot of art therapy, music therapy. There's just a lot of different therapies, and they differ.
That's not what I asked.
Okay, what are you asking?
I'm asking specifically about body manipulation and massage to release the trauma that's kept inside the body.
To my knowledge, massage is not something that we do.
Okay.
Massage is not a form of therapy. It might be something that's recommended, but it's not something that we do
Feldenkrais
at our
or
locations.
Rolfing are very specific for this kind of work.
Mm-hmm.
And they've been used for decades and are the principal treatments in Europe.
Excellent. Maybe you could also share that information with the panel to share with the group. That's
Okay.
not something I'm familiar with. I'm familiar with massage, but not as a trauma movement. Any other
Someone else
questions?
has their hand up? Do you want to unmute yourself? Yeah.
Oh, okay. I had my virtual hand up. So I don't know if I have more of a question or a comment. I really did appreciate you mentioning going back to sort of the old medicine, going back to the basics, and how many of the sort of like older treatments for illnesses have been downplayed or not really researched well enough. And that's one of the reasons I'm just really passionate about, really looking at what's happened in our system, especially in America, what's been highlighted, and how many of those treatments are funded by larger corporations or pharmaceutical companies, It's about making money and getting away from what really works. So thank you for at least mentioning that, and any additional info that you have on that will really help me in some of the work that I do as I talk about,
Mhm.
looking at how our system has failed us. Okay, thank
Yeah,
you.
I personally have a holistic doctor as my primary care physician. I have a functional medicine doctor as my OB-GYN, and I see a naturopathic doctor for supplements. So I am very much personally engaged in natural health as much as possible.
I wanted to say as well, I was so excited to hear you speak about those. When I was in university, I was studying medical anthropology, and I did a lot of research on alternative treatments for like depression and such. I think trauma was not such a big thing back then, but I found that like Ayurvedic treatment and Chinese medicine was so
Mhm.
helpful, in acupuncture, and of course, meditation and changing in diets. And I'm also a veteran. And, for years, I had to fight the VA about trying to
Right.
give me and other vets so much medicine. And thankfully now they are coming around and offering, Tai Chi and Qigong and, acupuncture and chiropractic, even though they're still a little off. They feel like you can't have these modalities at the same time, which is like totally ridiculous. But they make you choose one or the other, at a particular time. But, with a lot of fight, things are coming around, and they are like getting away from, they're seeing the effects of putting so many veterans on medication for whether it's for pain or mental health things, and how it has not been effective. So I am so
Yeah.
appreciative of your work, and it's nice to know I'm not out here alone.
Right. And Tiffany, you know how they never argue about being on multiple medications at a time that actually contradict one another and create the symptoms that they then give you another medication for? That's what just makes me angry, because it's like these integrative therapies. It's where I've had to change my mindset about being upset that my insurance won't cover the methods that I want to use. And I just get the high deductible plan because it's the cheapest. And then I put as much money as I can into my health savings plan, because I have a lot of freedom with that health savings plan to use that to pay for the methods that I want to use for me personally. I'm just building my immune system and staying healthy so that I don't get sick. Well, thank you very much, you guys, for your attendance today. I'm excited that you all came to the presentation. And again, if you have any questions or want to share any information with me, I welcome that. And you'll have my email and phone number, as well as Stephanie's, in the presentation the hard copy of the presentation that will follow.
And I want to thank you,
Thank you.
Shannon, too. Thanks for the wonderful presentation. You have us both as well, and you're amazing as always.
Aw, thank you. I didn't pay her, you guys. She's just my partner in work.
And Shannon will actually will be presenting next Friday on Indigenous and generational trauma. Sorry.
Yes,
So thank
yes,
you so much, Shannon.
and the majority of that presentation is going to be done by a tribal member. So I'm really excited about that.
Wonderful. Thank you.
Okay, we'll see you next week.
Thank you so much.
Take care.